Okay, so this is probably the first lecture in this new year for the new academic year, I mean. So far, we have put over 50 videos in the YouTube channel, ISCOM, so you can refer to it anytime. And I encourage you actually to go because it has been a harvest of 1.5 or 2 years. And there are so many amazing presentations there. And for this year, I wish we get better in terms of quality and also quantity. Well, I'm trying to get as many as possible of participants from the speaker side. We're going to see together how this new year is going to be. But I always encourage your suggestions as to how we are going to improve in terms of topics, material, way of presentation, your participation, how much you want to take your participation into this platform. And I wish even some of you can also give us some talks and stuff like that. So anyhow, it's going to be a kind of give and take communication between us and to discuss how are we going to improve. So don't shy away from giving any suggestion in terms of quality improvement, because upon your suggestion, we are going to stand and improve. Chest X-ray in cardiology used to be the first lecture the year before and before the year before the last. And it's a bit difficult topic because, you know, we always give a quick glance to the chest X-ray because we need it for congestion, basically, pleural effusion. And sometimes we see the size of the heart. And another purpose for using the chest X-ray in cardiology is checking the lines. Where is our central line? And where we, after we put a device like pacemaker, ICD, we always do chest X-ray to make sure that the positioning is fine and there is no complication. This is briefly, yani, when and how we use the chest X-ray in cardiology. But chest X-ray is still very rich, by the way, as a diagnostic tool. And I'm going to walk you through so many chest X-rays in this session and their relevance to cardiology and how we can read them. And also, as we always get used to, it's going to be an interactive session. Of course, the first thing we should know about is the PA and AP projection. Okay, you can say supine and erect. So this one is the supine when the patient is lying recumbent on bed, but this one is standing. When he lies recumbent in bed, therefore, you have to put the film on his back and the X-ray source is coming over. But if he can stand, the chest X-ray film is going to be here and the X-ray source is coming from behind. So this is supine and this is supine and erect, okay, or portable. Sometimes they're coming to the department. This one, I mean this one. So what's the difference between the two? The quality of the XR is more accurate here. So this one, is my sound still audible?
Now audible like
you lost it here.
Yes.
You lost it here.
Yes.
Yeah. I said there are two projections, the supine and the erect projection. This one is the erect and this one is supine. So in this one, the film comes in the back and the X-ray source come above the patient. While in the erect or standing, okay, the chest X-ray is on this side and the X-ray comes from behind. Now, usually for patients who are sick in bed and in CCU, ICU, we used to go portable and use the supine, which is AP projection. But we have to know that the AP projection, in terms of quality, is lower compared to this one. And the other thing is that it magnifies the size of the heart. So if the size of the heart here is 16, truly it's 13. So the heart shadow or the heart silhouette tends to get bigger in the AP supine projection. Okay, good. Now look at this one here. This is a chest X-ray in the PA projection. It is important we know this cardiac silhouette. What is it composed of? The left, the right border, and the left border, and the inferior border of the heart. So let's take a landmark here. This one is the carina, in which the trachea divides into left and main bronchus. This one here is the costophrenic angle, the right one, and the left costophrenic angle. This is the left cardiophrenic angle, the right cardiophrenic angle. Now, this is the hilum, right and left hilum. Then we come to the left border, aortic knob. Here is the pulmonary artery. Maybe the LA appendage comes here, and the left ventricle. The right border, here is the SVC and the right atrium. So the RV is not seen in the PAAP projection, and the left atrium is not seen. Okay, good. And if you see here in a schematic, you will know why. This is the right atrium, and this one is the LV. So this one is not actually seen because it is anterior. So we are not seeing the right ventricle, but we can see the imprint of the right ventricle when it's dilated, or we can see the right ventricle in the lateral X-ray orientation. Because in the lateral X-ray orientation, it's here, RV, it occupies the anterior space, and the LV is posterior, and IVC comes here, and ascending aorta, and the left atrium is also seen here, the most posterior structure of the heart. So the RV and LA are not seen in the APPA projection, but are seen in the lateral projection. So far, clear? Clear?
Yes, clear.
Good. So this one is here. You see, this is the right ventricle, precisely the RVOT, the left ventricle, and the left atrium. And here is the IVC. IVC. You can also judge about enlargement of the LV by how much it moves to cover from this space, and of the LV enlargement by how much it covers from the anterior mediastinal space. So in the lateral projection, there are ways to decide about chamber enlargement, which is different than the APPA projection. Okay, good. Now, the most important thing that is practiced by all of us is the assessment of the cardiothoracic ratio. And the cardiothoracic ratio basically is about the widest transverse cardiac diameter divided by the widest thoracic diameter. So where is the widest thoracic diameter? It's this one, the lowest one here. Okay, now the widest cardiac diameter, because the heart is oblique and we have to drop a perpendicular line through the spine and see the widest diameter on the left and the widest diameter on the right, and A plus B is the cardiac diameter, the widest cardiac diameter divided over C. So A plus B divided by C is the cardiothoracic ratio. In newborn, it's usually lower than 0.6. In adult, it is less than 0.5. Sometimes we refer to it by percentage instead of ratio, and we say 50% and stuff like that. So if the cardiothoracic ratio is, let's say, 0.6 or 60%, مثلا, that means the heart is big. Now, the sensitivity and specificity of cardiothoracic ratio. It is actually more specific than sensitive, and that means there are probably so many high false negatives. So you can miss large heart by doing this one. Specificity is reasonable, and that means the confidence, the diagnostic confidence of cardiothoracic ratio, if it's big, is reliable. Okay, the total accuracy is 0.59. Okay, لكن أنا هنا بنبه لنقطة مهمة. A large heart, يعني you have to make sure that first I'm not dealing with the AP projection, لأنه ال AP projection بيعمل magnification, false magnification of the cardiac cell wall. So we are referring to cardiothoracic ratio and its calculation by this way when we are looking at the PA projection. Okay? بعدين في حاجة ثانية مهمة إنه how many times you get a patient or you get referral from primary care or internal medicine for a patient whose chest X-ray is showing cardiomegaly, but when you do echo, there is nothing. So how can you explain that? Now, the mic is yours. How can you explain that?
Maybe the X-ray taken during expiration.
Okay, good. So the phase of the X-ray acquisition. 1, 2.
The position.
The position, يعني okay.
As you said about
yeah. AP or
supine,
PA.
BA or
good.
PAV,
Yes.
patient lying supine or
exactly. Yes. And the other thing is the tilt or rotation. Any tilt or rotation in the patient is going to magnify the cardiac size because it leads to obliquity in the heart. So the quality of the chest X-ray has to be straight. The patient is standing straight. If he is tilting to one side, stuff like that, leading to malrotation problem and an orientation problem, also the heart is going to be magnified. And the other thing which I also get amazed by is that sometimes, but actually I didn't find it in books or literature, sometimes, because what we are seeing here is what? These borders. These are borders, right? The outer borders of the heart. Is it the myocardium? No, not necessarily. Because the outer border of the heart, as seen in X-ray, is the very outer, is the outermost. So I'm going to take you to echo and imagine with me the parasternal lung axis. What do you see there? From uppermost going down, we see mediastinal fat, then pericardial fat, then epicardial fat, then the RV border, then the LV, then. So the heart is encased in fat pad, and this fat might be big. So what we are seeing here might be magnified by the amount of fat around the heart. Okay, so I think fat is also having a role to play in magnifying the cardiac silhouette. Good. Now, this is the way you see here. The one on the left, the right way of checking it. Okay, so you are dropping a line perpendicular through the spine, checking the widest on the left, the widest on the right, add them together and divide them by the widest thoracic ratio. Doing it this way, it's faster, but less accurate. I wouldn't say this is starkly wrong, but it's not so accurate. Okay, it's better to go this way. Now look here. Yeah, so this is 2.9 centimeter on this side and 10 centimeter on this side. So total is like 13 centimeter over 31 or 32 centimeter. That's the cardiothoracic ratio. Okay, good. Now the borders. If I just take you back here, we said that this border, the left border here, is the aortic knuckle. The pulmonary artery comes here. The LA appendage comes somewhere here, and the LV. Okay? So if you see a bulge coming here, because you are not seeing the structure, you are guessing by their common location. So if you see a bulge coming here, you are more likely to think of it as what? As pulmonary artery dilatation. Okay? Like this one here. Or because the pulmonary artery is a bit high here, this might be, you might think of it as LA appendage dilatation. But actually, this was a case of saccular coronary aneurysm and fistula. So this was a coronary aneurysm that bulges out and it distorted the left border in this way. ده معناته شنو؟ معناته the borders of the heart reflects particular structure by the rule of commonality. ولكن you have to make sure that sometimes الهارت فيه حاجات can enlarge and can go on this border or that border beyond the common structures on the left and on the right. So you have to be humble when you are interpreting the borders of the heart. You have to be humble. It's not always, categorical. This is so and this is so. No. Okay? Remember this one. Now, what do you think in this chest X-ray? Okay, the mic is yours.
This is BA, chest X-ray.
Yeah. And this one is?
Increased cardiac silhouette.
Okay.
Mainly the left ventricles.
Okay. And what else?
This calcification.
Yeah.
There is calcification around the heart body.
Yes. Right, Ahmed. That is calcification. Okay.
Yes.
So this is PA and this is lateral. And you see here glimpses of calcium. But when you do the lateral, you see the calcium better depicted. And this is the rule. Lateral X-ray is better than AP and PA projection for illustrating pericardial calcification. Okay, good. This is important. So if you are looking for pericardial calcification in a patient with constrictive pericarditis, I think you need to order lateral, not APPA. Okay, lateral. See, the difference is really magnificent. You see here how clearly you could see the calcium, where you missed a lot of it here and you see just glimpses. And if you don't focus, you might even have missed it completely. So the lateral, unlikely to miss the calcification, but quite likely to miss calcification by the PA. Okay, so this is a case of precardial calcification. Once you see this precardial calcification, let's say you stumbled into this precardial calcification, reviewing this chest X-ray for some other purpose. What next step you are gonna take? What's your next step?
I think CT scan.
Okay, good. CT scan, why?
I'm not sure, but I think it can give you a score about the degree of calcification.
To confirm a calcification.
Diagnostic tool is the best ever, the best in terms of calcification. It is the cardiac CT. Okay, is my sound okay?
Yes.
Huh?
Okay.
Yeah, okay. So cardiac CT is the best in depicting calcification, precardial calcification, and to quantify it and to see exactly the distribution of calcium. So cardiac CT is part and parcel of precardial or constrictive pericarditis workup. Lakin, I'm asking you again, the next step after you see this chest X-ray. You have seen the chest X-ray, but you haven't seen the patient yet. So what's the next step? To see the patient and to do clinical evaluation for constriction, okay, in terms of symptoms and signs. Now, next step. Let's assume that the patient is doing fine, no clinical signs of constriction. Next step, خلاص, you are happy and the patient can go home reassured, or you are gonna do something.
We will do echo.
Yes, exactly. So for any precardial calcification, this much you ought to order echo. Why should I bother? Because echo might reveal constriction physiology way ahead of clinical manifestation. So don't rely on clinical manifestation alone. Don't assume that if I don't have clinical constrictive pericarditis, I'm not gonna bother. No, you have to be proactive. So you have to diagnose constriction before it impacts the clinical status of the patient, because you can start management right from there. Okay, so you see the hierarchy: clinical evaluation, echo, and then if the patient is for let's say for surgical precardial stripping, then you have to order cardiac CT. Okay. Now, what is this? The mic is yours. Who's gonna take this? Mm-hmm. I might. Yes,
I
go
think
ahead.
there is an air fluid level behind the heart.
Yeah, it's very good, Yamazi. Actually, you snatched the diagnosis. Exactly. So what do you think about this? Yeah, Mazin is talking about this air fluid level behind the heart. I don't know if it's behind the heart or in front of the heart, but once I see this air fluid level and this location, central, overlapping the heart, I will assume that is posterior, and this is hiatus hernia. Big one. Big one. Okay? Okay?
Okay.
Yes. Now, the level of congestions, which is important for us. You know, initially, when the patient, before we see patient at this stage, probably he passes through milder stage of congestion. And the first stage we usually allude to is the cephalization of the vein. So, or upper lobe diversion of the veins like this one. So you see the venous system is congested upwardly or epically. Then if you focus at the mid-lower zones, you will see careless B lines here, careless B lines. And then a level of congestion, which you can refer to it as level 3, level 1, level 2, or level 1 and level 2 is here. The hilar filling or batwing, and then the florid sort of pulmonary edema with whiting out of both lung fields. So the congestion has stages, right? Has stages. So if you have a patient with decompensated heart failure, don't expect you are gonna just see chest X-ray like this or even like this. The patient might just be at this stage or careless B-line stage. So you have to scan the chest X-ray carefully and thoroughly before you dismiss the patient as having no radiological evidence of congestion. Now, the pleural effusion is also a bit tricky sometimes, and that's why if it's big, you know, like some few chest X-rays here, that wouldn't be a problem, but sometimes it's small. Like if you look here, just, you know, the straightening of the costophrenic angle is a tip off to pericardial calcification here. Again, here is also a bit of elusive. If you don't focus, you might miss it, but this is also pericardial effusion. This is a sort of insisted pericardial effusion. This one is large pericardial effusion as well as this one. And this is massive pericardial effusion, shifting the mediastinal rightward, okay? So there are different levels of pleural effusions as well. Now, the question is, with decompensated heart failure, which location of pericardial effusion are we going to expect? Left or right or both?
Right.
Right.
More in the right.
More on the right, yes. More on the right, more prominent on the right, which is on this side here, than on this side here. Okay. But as far as the physiology is concerned, once you have heart failure leads to increased hydrostatic pressure and exudation of fluid in both pleural cavities. So why it becomes prominent on the left more? So why it become prominent on the right than the left? Because physiologically, I'm expecting to have equally bilateral pleural effusion in heart failure. Why? Because there is gravity effect upon the fluid. So the fluid increase on the dependent area. While annual patient of heart failure, if he had heart failure, and you can ask your patient about this, they prefer to sleep on the right side, not on the left side. So when they are sleeping on the right side, so the gravity and the dependent part in the right side, pooling of fluid increases on the right side because of gravity, not because of the physiology. Physiology of heart failure, oxidate fluid actually equally in both pleural cavities, but the gravity makes it more prominent on the right than on the left. Okay? So you get this point?
Yes, okay.
Good. Now, I need somebody to tell me what she sees in this chest X-ray. Mm-hmm. I'm going to give you a glimpse here. This is a pectoral catheter for a patient who underwent pericardiocentesis, and the catheter is still in situ. So we are seeing it here. So And it ends here, by the way. It probably ends here. That is not the catheter. This is parietal pericardium. This is the parietal pericardium, and this is also the parietal pericardium. And there is echolucency here and echolucency here, but more prominent here than here. So what is this? This is pneumopericardium, which is one of the complications of cardiocentesis. You can introduce L cavity, and like the air. So, ladies and gentlemen, anytime you lose my sound, please let me know, because I'm in a place where the connection is not stable. So, is my sound clear so far?
Yes, it is clear.
Okay. So the fluid goes dependently down by gravity, and the air goes dependently up. So if you have air, it tends to go up. If you have fluid, it tends to gravitate down. That's why you have more air here than on this side, and of course, than in the inferior side of the heart. That's why this is air. And this pericardium is thick. It's quite thick. It's actually supposed to be a thin thread, hardly appreciable. But this one is stout, standing out because of involvement in metastasis. This is location of cancer. This is malignant pericardial effusion with metastasis to the pericardium. Okay, so this is a pneumopericardium. Good. This is again chest X-ray, which is the PA showing calcification here, hardly seen, and the extent of which is not so clear. But after you do the lab,
We miss sound levels.
just a guess. Guess.
Sorry, Abbas, we missed the sound.
You missed the sound? Okay, good. Anytime, please, you miss the sound, let me know, okay? So I'm asking, what are these arrows pointing to? Take a guess. Take a guess. Did you hear me?
Yes.
Huh? Okay. Okay, so these are
It's pointing to the aortic valve, yeah, Hatim.
it is not even if you focus more, you see this is kind of linear radio opaque density, and the location does not actually belong to the aortic valve, because you see it's going towards the left border of the heart. So this is coronary calcification. So you can see coronary calcification by chest X-ray. You can sometimes see the stents. Yes. Okay. So this is coronary calcification. Okay. Now, anybody can take this? Who can take it? Just a guess.
Yes, I will take it. Ahmed.
Go ahead.
This is just X-ray, BA view. Show increase cardiac shadow. is pulmonary congestion.
Okay, I agree with you. So there is features of pulmonary congestion. There is hilar filling and there is upper lobe cephalization. Yes, good, good. And I just want to take you to this. What do you think about this calcification here? This one.
Maybe coronary sinus calcification.
Or another
Or,
guess?
Mitral valve.
Very good. Mitral valve. Who said so?
Me, Mazin.
Mazin. Yes. Mazin, you are so right. This is mitral valve calcification. And if you look here, it's kind of curvilinear because it's tracking the annulus. So this is mitral annular calcification. Okay, curvilinear sort of. Yani sometimes you feel it's standing out like a prosthetic valve. Okay, so this is mitral annular calcification. Okay, good. And any guess? Any guess?
Maybe aortic aneurysm with calcification.
Aortic aneurysm with calcification. Okay. Yeah. I wouldn't say you are wrong because the aorta comes posteriorly, so it might appear this way. Yes. Yeah. Good guess. Good guess. Because you know this underscores and emphasizes the first thing we have talked about. Once you see something, some structure, it's very hard to precisely locate this structure by the chest X-ray, because it might be anything in this direction, anteriorly to posteriorly. So this one here can be any structure from the sternum to the spine. Okay, yes, it can be. Lakin, so your guess is right. I wouldn't say it's wrong. But in this case, this is the left atrial calcification. And I just remind you one more time that the left atrium and the right ventricle makes no border in the heart silhouette or share no borders. So you don't see them. Unless sometime when they are large, they manifest in a special way. That is PAAP chest X-ray. But the lateral, you can see the RV and you can see the left atrium in the lateral, as we have seen. So this one here is left atrial wall calcification. And by the way, it's not uncommon to see calcification just because of the remodeling, you know, remodeling for any reason. Let's say this patient is having chronic atrial fibrillation with dilatation, diastolic dysfunction with dilatation, or MSMR. It might lead to this amount of left atrial wall calcification. Okay, another guess. What are you seeing here? What are we seeing here? Yes. Anybody?
Also, I think coronary calcification also.
Coronary calcification or?
Lima.
Lima. I think somebody said chronic calcification or stent, right? And I think I totally agree with you. This is either chronic calcification or stent, but this is a case of stent, okay? So the stent can also be seen sometimes, but not always, in the chest X-ray like this. So this is a stent, okay? Stent. Now, This is another calcification. You see it here in the PA, and you see it here in the lateral X-ray. So do you think this is precardial calcification or something else? Is it precardial calcification or no? Did you hear my question?
Yes, I think not pericardial.
Yes, this is not precardial. Because you see, the border of the heart are here. These are the borders here. And this one is encircling some other place. Encircling some other place. This is the location of what? LV apex. So if you see a curvilinear calcification density along the apex, what are you suspecting then? This is epical aneurysm with calcification. You know, epical aneurysm with calcification. And this is part of the aneurysmal apex remodeling. You know, it thins out, it becomes fibrotic, and it might trap calcium and become calcified. So calcification of the aneurysm is the natural progression of aneurysmal apex. It might get calcified, and it might get calcified to the extent that you can see it in the chest X-ray like this. Okay, so now I'm showing you different calcification density in the chest X-ray. I'm trying to, you know, get you to the art of seeing which is which or guessing which is which. Now, what is this? Again, this one here is, we have seen an example of it. Again, this is a curvilinear in the location of the mitral valve. Yes, so this is again MAC. This is MAC. Okay, and if you draw a line from the hilum toward the costo-cardiac angle or the costophrenic angle here, the valve below this line is the mitral valve. Above this line is the aortic valve. Let's do this one in the lateral X-ray. The hilum is here, and I'm taking an angle or a line to this angle. So I have a density that's above this line. So this density most likely is what? This one is aortic. This is aortic. So this is aortic calcification. This is aortic valve calcification, and this is mitral annular calcification. Okay. And another thing is that the MAC is broader than the aortic calcification because the area of the annular mitral annular is bigger than the aortic annular diameter. Okay. And again here, if you look again, there is also calcification here. And if you drop your imaginary line, it's falling above. So this is aortic calcification again, is less than the one I showed you before. But if you look here, do you appreciate any aortic calcification? Not really. This X-ray is the lateral X-ray of this same patient. And this again emphasizes the importance of lateral X-ray when you are looking for calcification. All types of calcification probably are seen better in the lateral than the AP and PA view. Now, another section which is also important, and I want you to get acquainted with, is how you read the X-ray of devices, and in particular, the pacemaker, the ICDs, and the CRT. So this is a pacemaker. Look at the pacemaker, how this is a photography of a pacemaker, and this is the radiograph of a pacemaker, and this is a photography of the ICD lead, and this is the radiograph of the ICD lead. So you see the difference here, the coil. You see this coil here? Small density here. But when you look at the ICD, there are proximal and distal large coils like this, and they are seen clearly in the X-ray. So you can tell that this is an ICD lead, not pacemaker lead, by seeing the coils, the proximal and distal coil, or the proximal and distal coil. Okay? Are you following me?
Okay.
So are you ready for the exercise now? Now, what do you think? Pacemaker, generator, the leads, the left atrial lead, and the RV lead. And in the lateral X-ray, right atrial lead, a right ventricular lead. Right atrial lead, a right ventricular lead. What device is this? What device is this?
Good number.
Huh?
Good number.
Yes, exactly. It's pacemaker, dual chamber pacemaker. You are right. And what is this here? RV lead, single. Okay, so this is single lead pacemaker. This one is
Dual.
dual. What is it? Pacemaker?
Yes.
Yes. And what is this then? I'm seeing a lead here, but I'm seeing some lead going laterally. What is this?
CRTD.
Yes.
CRT.
Yes. So this lead is passing through the coronary sinus to the lateral posterior cardiac vein. So this is cardiac resynchronization lead. Now, what is this? What is this device?
ICD.
Yes.
ICD.
Why? Because the two coils, this one and this one. Okay. Now, what is this?
ICD.
Yes, dual chamber ICD. This is single chamber ICD. Again, this is ICD because of this coil and this coil, and you see the RA lead is here. Okay? Clear so far? Good. Now, what is this? This one here.
ICD.
ICD. Only ICD.
CRTD.
Okay, yes. So you can say it is bivent ICD, or you could say ICD slash CRT, whichever you like to choose. But here we are seeing three leads, right atrial lead, RV lead, and coronary sinus lead. Here in the lateral X-ray, the coronary sinus lead is here, the RV lead is here, and the RA lead is here, this one. Okay? Now, this one is RV lead and coronary sinus lead. And there is also RA lead here. The lateral X-ray is showing it also. The RA lead is here, the RV lead is here, and the coronary sinus lead is this one. So these are ICD, CRT, or bivent ICD. Okay, so what are we seeing here now? This device of the same patient after some time. So what is this? This is what?
ICD.
ICD lead. Thank you. Now, this is the same patient few months later. What happens to this device? What happens to this device? Huh? First of all, do you think the position of the RV lead is as it is here, or no? Yeah, exactly. So here,
Yes.
yeah, exactly. And the position of the generator, is it in the same size or it goes down? Huh? Yeah. So what happens here is that the position of the pacemaker generator, or the the ICD, goes down. There is coiling and distortion of the leads here, and there is what? Detachment detachment. Okay, it gets detached, the RV lead. Now this is a patient after ICD insertion, and this is the same patient few months later or few days later. So again, the generator went down, pulled away from its original site, and there is coiling and winding of the leads, and the leads has gone up. So what is this? This is called Twidler syndrome. Twidler syndrome. And I wish there is some sound in the background. So those who are not talking, yes, thank you so much. Now, the Twidler syndrome, sometimes the patient might touch the pocket a lot, and plays on it and do twisting and untwisting, sometimes consciously, sometimes unconsciously. That might lead to a damage of the device, especially in the early stage of the device implantation, when it's not yet fibrotic and steady. So it might move and migrate from its side, and it pulls the lead with it. It pulls the lead with it. Okay, so this is important. That's why it's part of the counseling of patient, is not to play on this site, because it might lead to this part, this damaging scenario, when the device migrates and it pulls the lead away. And once the lead is pulled away, the problem sometimes the patient comes up. First of all, the pacemaker will go malfunctioning. It will lose its capture and stuff like that. Sometime while the lead is coming up, it might stimulate something in its way. And that is what? The phrenic nerve. The phrenic nerve comes this way, this way. You see the phrenic nerves comes here. So when this one is detached, it comes here, it can stimulate the phrenic nerve. So a patient after a pacemaker implantation comes to you complaining of abdominal pulsation, and you see his tummy and it's pulsating, that means this is phrenic nerve stimulation because of detached RV lead stimulating the phrenic nerve. Twidler syndrome. Twidler syndrome. Okay, so remember this one. Again, you see here, this is after implantation. The RV, this is the LA lead here. I don't see the RV lead, but look at the also, yeah, there is RV lead. Look here how the device migrated distally because of Twidler syndrome, and it brought the leads up. So this RV, this is probably the RA lead, and this is RV lead. And this RV lead in this position can stimulate the phrenic nerve and leads to diaphragmatic pacing. It paces the diaphragm and leads to abdominal pulsation, distressing abdominal pulsation sometimes. Okay? Good. So what is this? What is this?
This is leadless
Yes.
pacemaker.
Yes, this is leadless pacemaker. It's implanted without leads, wireless or leadless, or the Medtronic one is called Micra. Okay. So you are gonna see it this way, and it's attractive, because you implant them without leads, so you are not so invasive on one side, and the other thing, you avoid the potential problems associated with leads and infection and generator and pocket infection and all of that. But it has a problem. Yani, one might ask why we don't replace all pacemaker with just this leadless, and that's it. Why? Haven't you asked yourself this question before? Because it looks attractive, a small device like this. Okay, you go to the RV and you deploy it there. It has hooks, it anchors to the RV, you leave it there. Finish. No leads, nothing. The problem is, it is It is what? Only RV pacing. It's not dual pacing. It's only RV pacing. Okay? لكن انت في pacemaker, you look for dual pacing because dual pacing is more physiological than single chamber pacing. Okay, so this is one thing. But you know, the technology is advancing, and I knew from my colleagues in EP that there is a device that now are equipped with a Bluetooth, so it can interrogate the atrial. Sorry. Hello, are you following me?
Yes,
Hello?
we are fine.
Yeah.
Yes, we are fine.
Yeah, good. So I told you that there are some devices, or they are working on a device which is equipped with a software, so it can interrogate the atrial ECG or the atrial electrical activity and synchronize the pacing with it. So it's kind of, you know, advanced software. And in this case, it might work like dual chamber pacemaker. So the technology is advancing, the technology is going on. So probably the leadless wireless pacemaker might take over the field of pacemakers. Good. Now, what is this device? What is this device?
Loop record.
Yes, this is loop recorder for patient whom you suspect they have arrhythmia of some kind, which is infrequent. So you want to check for it over a long duration of time, because these devices can be implanted and left in place for years, and you can interrogate them from time to time. And they record the ECG. They have good memory, storage memory. Okay, so they record, especially when the patient is having symptoms. You know, you ask the patient to press a button, okay, and the ECG is recorded before, during, and after this event, so you could interrogate and see what kind of arrhythmia the patient is having during the period of his symptoms. So this is loop recorder. The one we are using usually is Reveal, which is this one here, Reveal, and it's put here. These are all acceptable sites and locations for the Reveal device. So whenever you see something like this, remember the loop recorders. And what is this? What is this?
Epicordial.
Very good, very good, very good. Iman, thank you. Yes, this, yes, this is epicardial pacemaker. The epicardial pacing wire is put surgically. If during cardiac surgery they put it in case they need it, okay, they stitch it to the pericardium and they keep it. Sometimes they keep it, sometimes they just by you know, simple traction, they remove it after surgery if they don't need it anymore. Okay, so sometimes you can see it this way, and remember it is epicardial lead. And this patient is having cardiac surgery before, because you see the sternal wires. You see the sternal wires here, sternal wires here. Okay, so this patient is having cardiac surgery. Okay, good. Okay, now I want you to see here. This is a right generator, right-sided generator. I'm zooming in here. What you see in this lead? What's the problem in this?
Fracture.
Yes, this is lead fracture. Thank you so much. And here, this is before and this is after the event. What is this event? Is fracture. You see, the fracture is not necessarily complete separation. Sometimes you see it like this, or sometimes even subtler, like this one here. So this is very subtle, tiny fracture. This is fracture, and this is complete separation of the leads. So when we talk about fracture, don't scan the X-ray for actual separation of leads. You have to zoom in And look, because it might just be like this, or it might just be like this, a tiny crack, hardly appreciable unless you focus so carefully. Okay, so lead fractures, you have to scan the X-ray carefully. Again here, look at the lead fracture proximally here, and here you see the lead fracture in the midway. See here? So these are lead fractures. Now, what is the problem here? This problem, this X-ray. Any guess? Any guess?
Perforation.
Exactly, lead perforation. Yeah, you see, the lead is kind of awkward position, you know. Yani, if we consider this is a funded gas, gastric gas, this is somewhere below, you know, below the cardiac borders. But I think in this lead, the X-ray might be deceptive, by the way. Yani sometime by the X-ray, you might feel, from my own experience, you might feel that the lead is beyond the boundaries of the heart, but it is not. And that's why probably you need to enhance your diagnostic accuracy by enlisting some other imaging tool. Or even in this one, if you request lateral, it might also be helpful. So the lateral might give you a better idea. But they have done CT, and the CT has shown that the lead has perforated the RV. You see the RV dimension here, and the lead is seen beyond the RV border. So this is a case of lead perforation. Lead perforation, okay? Now, if you are given a chest X-ray of prosthetic valve, again, you have to know which valve you are dealing with, how they imprint their persona in the X-ray. This is mitral, tricuspid, aortic, and pulmonary. In the lateral, if you draw this line, mitral tricuspid is below the line, aortic and pulmonary is above the line. The pulmonary is the highermost. Okay? Now, what is this? Any taker? What is this? Uh-huh. Mm-hmm.
Yellow
Mitral
arrow
valve.
is the mitral valve, and the white arrow is the aortic valve.
Yes, Mazen, you are right. You are right. You are so right. Okay. So this one here is the mitral. This is the aortic. In zooming, the mitral and aortic, both are metallic valves. You see the sewing ring and probably the imprint of the disc here. So these are metallic valves. And you see here, again, you remember, if you draw a line from the hilum going toward the costophrenic angle, below it is the mitral, above it is the aortic. The other thing is that if you have them both, it's easy to tell which is which because the mitral valve is bigger. The mitral valve is bigger than the aortic valve. So this is mitral and this is aortic. Both are metallic valves. Now, what is this here? The one I am pointing to.
This is TAVI.
Exactly. This is TAVI. So this is a prosthetic valve, okay, in the position of the mitral valve. And what is this? I'm gonna bring you back here. See here, see the pulmonary valve, how it looks in the lateral, or where it's positioned in the lateral X-ray. Compare this with this one here. So this one is what? It's not the aortic. This is the pulmonary. So this is a pulmonary prosthesis. A pulmonary prosthesis. This is aortic prosthesis in PA and lateral, and this is pulmonary prosthesis in PA and lateral. You see, the location is quite different, okay? So the pulmonary valve tends to be the most superior valve in the PA and lateral in comparison to the aortic valve. This is called melody valve, okay? It's also implanted percutaneously, melody valve, just like TAVI, okay? Good. Now, what is this? What is this? This one here.
Mitral clip.
Yes, this is the mitral clip. So you can see the mitral clip in X-ray. You can see 1, 2, or 3 because sometimes they put 2 or 3 clips for the same patient. So this is mitral clip, and this is how it looks actually. And this is the clip during the procedure. So mitral clip in chest X-ray can be well seen. Now, tell me, I need someone to take it. It's easy. What are these valves? You see, now the lateral usually separate the echo densities nicely, and you can see them better than PA view. But here I'm seeing 3 radio-opaque structure with persona. This one, and this one. In the lateral, I'm seeing this one, and this one. So, anybody can take it? What is this?
This is mitral.
Mitral. Very good. And this one?
Aortic.
Aortic.
Very good. And this one?
Tricuspid.
Tricuspid. Exactly. Back. Mitral what? Mitral what?
Valve. Tissue valve.
Tissue valve. Aortic what?
Tissue also.
Yes. And tricuspid what?
Ring.
Ring. Thank you so much. Good. Well done. Now, what are we seeing here? Anybody can take this?
This is the mitral valve.
Yes, very good. Mitral bioprosthesis. Agree with you. What else?
Tricuspid.
Very good. Tricuspid repairing. And
Lead.
what
Going
is
through
this
the
lead?
track.
Is it pacemaker or ICD lead? No,
Pacemaker.
it's pacemaker. We have
Pacemaker.
shown the difference. There is no
Yes.
coil. The pacemaker, you will always see something like this. I'm taking you back. I'm taking you back here, okay? Because this is important, okay? See, you are gonna see coil here and coil here. If you don't see these coils and you just see something like this, this is pacemaker.
A pacemaker.
Okay, so this is pacemaker. Okay, and yeah, and these are sternal wires. As you see, sternal wires are here. Good, you are doing so fine. Now, anybody can tell me what is he or she seeing?
This is an occlusive device for
Very
VSD.
good. Yes, this is occluder device, interatrial occluder device. This one here, this is another type of occluder device, and this is occluder device. This is probably Platzer, maybe this is Rashkind or Rashkind. There are different type of occluder device, the Platzer and stuff like that. Okay, this is how they look like in terms of location and morphology. Okay, what are we seeing here? Focus here. Here, do you see anything here? This one here?
This is a clip for
Yes. This one, yes. Yes. These are what? Eh? What did you say about this?
Clips for limograft.
Yes. Yes. These are clips of the limograft. Yes. Clips of limograft are seen this way. Agree with you. But I want you to focus here. This part, which is zoomed in here. It's zoomed. So what is this? What is this structure here? You remember we said this part of the border is occupied by the pulmonary and the LA appendage. So this is something relating to the LA appendage. So what is it?
Occluder device.
Yes, this is a occluder device, namely Watchman device. This is Watchman device. So you see how Watchman device looks like? This is it. And this is Watchman device in cardiac CT. Watchman device. Okay. Good. So this is Watchman device. Good. Now, what is this? Any guess? Any guess? Just a guess.
Livad.
Sorry?
Livad.
Device.
Wallah ya Iman, thank you so much. This is LVAD, exactly. This is LVAD. You see, this cannula is inserted into the LV and it takes blood. It sucks the blood from the LV. It goes into a pump, okay? And through a cannula into the proximal ascending aorta. You see? So this is LVAD, left ventricular assist device. Okay, you are so right. And this patient is having an ICD. You see the coils, it's an ICD. Okay, probably even CRT, I don't know. But this is LVAD. Okay, good. Now, if this is LVAD, what is this? No, but close. You are close. No, you see, LVAD is something external. So external, because you know the cannula is inserted into the LV and it has an outer part with another cannula that goes into the proximal aorta. So it sucks blood from the LV and force it into the aorta to bypass the left ventricle, to relax and rest the left ventricle, and to bridge the heart for destination therapy or whatever, okay? So it acts like assist device because the LV is too weak to pump the blood. So the blood is sucked into a pump and the pump pushes the blood into the aorta. This is LVAD. But what is this?
Balloon, intra-aortic balloon.
No.
Impella.
Impella. Thank you so much. This is impella. An impella, it has an inlet tube, an outlet. So again, it works the same function, you know, of the LVAD, but from internal. So it's put in the LV. So it sucks blood through this inlet cannula. And there is a pump that pushes the blood here above the aortic valve. So it pushes the blood. So again, it is bypassing or relaxing or resting the LV, or guaranteeing adequate cardiac output during high-risk PCIs, because this is one of the indications for impella. High-risk PCIs, cardiogenic shock, or bridge, mechanical support bridge in patient with severe heart failure, you know. So this is impella. So you now know the personalities of these devices and how they look in X-ray. Now, you have talked about intra-aortic balloon pump. This is intra-aortic balloon pump. It's here. The only part that we see in intra-aortic balloon pump is only this radio-opaque line in the proximal portion of the descending aorta. That's all you see in the chest X-ray. And this is important and made radio-opaque because you can judge about the location, if it is high or down, and you adjust the position. Okay, so this is correctly located intra-aortic balloon pump. Now, what is this?
Pulmonary wedge catheter.
Yes. So this is Swan-Ganz catheter. You are right. And you see طبعا the sternal wires, and probably this patient is having maybe tricuspid ring here, this one. And this one is a Swan-Ganz catheter. This catheter and this catheter, this is for the same patient after manipulation. Which one is the right position? Is it this one or this one? Because you request chest x-ray after you put Swan-Ganz to decide about the correct positioning. But also the tracing, you know, the hemodynamic tracing is also giving you an idea if you are properly positioned or not. But the chest x-ray is also important. This one is going into a branch lobar pulmonary artery, which is wrong. You have to pull it back. You position it this way. It has to be relaxed without hooks and kinks. So like this one, it will be in the pulmonary artery, okay? Not in the branch pulmonary arteries, okay? So this one has gone too deep. It's pulled back and made straight like this. This is the correct position of the Swan-Ganz catheter. Okay, what is this here? What is it?
Mitral ring.
Mitral ring. Thank you so much. There is mitral ring. There is sternal wires. Sternal wires, you see them here. Good. What else? If I ask you, what do you think about the cardiac border? It's dilated. And this is breast shadows. These are breast shadows. Okay. But do you think that the heart is big?
Double borders.
Yes, thank you so much. So there is double border. Thank you. You know, we have mentioned right from the outset, when we were explaining and discussing the borders in the cardiac cell width, that the left atrium is not seen in the borders. The RV is not seen in the borders. But there is a way to tell if the left atrium is large by this one here, the double density. This density here is the density of the right border of the heart, which is occupied by the right atrium. If the left atrium is big enough, it comes here and it prints its shadow silhouette. So you see like double density sign, RV, oh, sorry, RA density and RA density. So it is kind of double density sign. Double density sign indicates dilated left atrium. Okay, so this is a dilated left atrium. What are the signs of dilated left atrium in this chest x-ray? Another circumstantial evidences of dilated left atrium.
Straightness of the left border.
Straightening of the carina.
Carinal angulation. You know, when there is splaying of the carina, when the angle is more than 90 degrees, like the one here, it becomes an obtuse angle. This is an evidence of left atrial dilatation. Good. And here, this is the double density. You see, the density of the RV overlapping with the density of the left atrium. And here is displaying of the carina, the angle is more than 90 degrees. And if you do the lateral X-ray, you will see that the displaying of the carina takes this sign, which they call it walking man sign. Walking man sign, because you see the left main bronchus and the right main bronchus are displayed this way. It looks like a walking man, and they call it walking man sign. Okay. And if there is barium swallow, it happens to have barium swallow, the dilated left atrium might encroach upon the esophagus, leads to displacement and sometimes compression of the esophagus. Okay, so it can displace it and it can compress upon it. So dilated left atrium can be or can lead to dysphagia. Okay, good. Now what is this? a boot. I'm going to show you a better one. This one. What is this?
Follow tetralogy.
Yes, exactly. This is tetralogy of Fallot. Tetralogy of Fallot, the heart takes the boot-shaped sign or the boot-shaped heart. It looks like this one. Why it looks like this one? Because of two features. The constriction here and the exaggerated RV dilatation lifting the heart up. When you have RV dilatation, the heart tends to migrate a little bit superiorly. كأنه الاتاشمنت بتاعته للdiaphragm خفت شوية, بقى floating on the diaphragm instead of lying over the diaphragm. Okay, so the RV dilatation usually the glimpse to which is elevation of the heart. So the heart is elevated, and because in tetralogy of Fallot we have what? We have pulmonary atresia, right? Pulmonary stenosis. And in the pulmonary stenosis, so the kink here, which is occupied by the pulmonary artery, is constricted. So you see that the heart is big here or elevated, and it is concave here. That's why it gives a boot-shaped sign. So the boot-shaped sign is due to two: RV dilatation and the pulmonary atresia. The pulmonary atresia leads to concavity here, and the RV dilatation leads to convexity and elevation of the heart. So it looks this way. Now, what is this? They call it egg on side, or sometimes they call it egg on a string. Egg on a string or egg on side. This is transposition of great, transposition of great arteries. Okay, so the transposition of great arteries, the heart silhouette takes this morphology of egg on side or egg on a string. And this one is box-shaped heart. Box-shaped heart. Any guess? What could that be due to? Box-shaped heart could be due to what? Hello? Hello? Are you following me?
Yes, yes, yeah.
Oh, yeah. Good.
سامعينك والله لكن ما عرفنا.
Okay. So this is Epstein or Epstein anomaly. Again, there is severe RV dilatation and probably RA dilatation. So it gives this morphology. And you see here, the proximal part which is occupied by the great vessels and the pulmonary artery, because of reduced cardiac output and reduced flow across the pulmonary artery, it's a bit narrow. That's why it gives the morphology of chamber with the great vessels are small. So it's kind of box-shaped heart. Which chamber is large here? I want you to tell me which chamber is large in this. And you have the arrow. Again, this is double density. Double density. You see the left atrium is here, the right atrium is here. So dilated left atrium. Which chamber is dilated here? Which chamber is dilated here? And this is the lateral X-ray.
RV.
Yes, it's RV, because, you know, it tends to elevate the heart. And in the lateral X-ray, you see that the remaining aerated part of the lung is small. Now you see here it's occupying more than 2/3. Usually it occupies less than that. This is the right side, the right ventricle, you know. So if it was the right ventricle, we see that the dilatation is in towards this direction. So this is RV dilatation. And which chamber is large here? This one here.
Right
Again,
atrium.
A right atrium, very good. So the right atrium is dilated, and which other chamber is dilated? Also what? You see the heart is kind of standing or sitting on the diaphragm instead of lying on it. Once you appreciate that the heart is shying away from lying on the diaphragm, this is RV dilatation. You see here the attachment of the heart to the diaphragm is less of a surface area than it should because of the RV dilatation, because of the RV elevating the heart superiorly. So this is RV dilatation. Again, this is RV dilatation, but it's a bit tough. It's more appreciated in the lateral X-ray by occupying almost 2/3 of the anterior mediastinum. Okay, good. Now, what is this? Heart now is too big and flask shape or bottle, water bottle shape. This is water bottle shaped heart. Water bottle shaped heart is what?
Pericardial effusion.
Yes, exactly. Exactly. طبعا, by the way, don't be too confident, okay? Don't be too confident. If you see a heart like that, like this, you cannot say categorically this is pericardial effusion. It could just be cardiomegaly because of chamber enlargement, okay? So I am not confident at all to diagnose pericardial effusion based on chest X-ray. No matter how the morphology is romantically flask-shaped, water bottle-shaped, whatever. No. You might suspect it, yes, and that might hasten your way towards doing echoes and stuff like that, but you can never be categorical from the chest X-ray, never at all, okay? But this is, usually speaking, if the heart take this morphology, we need to suspect pericardial effusion. Again, you see the heart here is globular. Sometimes they call it globular heart, flask-shaped heart, water bottle heart. Sometimes they call it chicken on fence heart. يعني كأنه chicken قاعد على fence لأنه بقى broad قاعد على diaphragm كده. It looks like chicken on fence heart. So you see, these are all examples of pericardial effusions, flask-shaped heart, water bottle heart, and these pericardial effusions. Now, what is this? This is not pericardial effusion, but something close, which is what? This is pericardial cyst. And this is the typical location of pericardial cyst, the right cardiophrenic angle. The right cardiophrenic angle is the typical location of pericardial cyst. So this is pericardial cyst, okay? Are you following so far?
Yes.
Yeah,
Yes.
don't worry, we are close to finish. I'm so sorry, I bored you really a lot today, but I meant to finish with the chest X-ray. Now, what is this? Ribs. I'm showing you the ribs. What do you see in them?
Notching.
Very good.
Notching.
Rib notching. So this is a sign of,
Coarctation of aorta.
Coarctation of the aorta.
and why? Why in coarctation of the aorta you have rib notching?
This
Due to
is,
collateral.
Yes,
collateral.
because of the collaterals, stout, prolific collaterals compressing on the bones from inside, leading to this kind of notching by compression effect. Notching. Okay, good. So this is, you see this a coarctation, you see this sign, they call it figure of 3 sign, figure of 3. You see here, this one and this one. Here is the site of constriction or coarctation, and here is a little bit of post-stenotic dilatation. So it gives a kind of figure of 3, figure of 3. You also see the rib notching, which are here, the rib notching. Okay, so this is a case of coarctation. Now, what is this? Now, what is this?
Wide mediastinum.
Yes, very good. This is the right prescription. This is wide upper mediastinum. Now, for me as a cardiologist and for you as a cardiologist, the most feared diagnosis, if you see this chest X-ray, is what?
Aortic dissection.
Very good, aortic dissection. So if you see this chest X-ray without seeing a patient, will you say this is dissection? No, but you are going to give dissection as one of the differential diagnoses. It could be any mass. You know, it could be just aortic aneurysm. It could be thymus, thyroidal, retrosternal, whatever, and lymph nodes. I don't know. It could be a lot, you know, because in the chest X-ray, you are seeing a shadow and you don't know from where it comes. It can come from anywhere, from the bone up to the spine. But I will be concerned about dissection, because dissection looks like this. So if I have a patient with chest pain that is dissection-like, and then I have this chest X-ray, yes, then I'm going to activate the team to adapt to this emergency like, and this is dissection. Yeah. Okay. Okay. And here is the pulmonary artery dilatation. This is pulmonary artery dilatation, left and right in a patient of pulmonary hypertension. And this is extreme form of pulmonary artery dilatations in a patient of pulmonary hypertension. Now, what is this? If you see this one here, which look like the Turkish sword, this is what? Scimitar. This is
anomalous drainage of the
Yes.
left pulmonary.
Very good. This is scimitar syndrome, which is anomalous. You see here, the pulmonary artery, instead of going to the left side, it goes to the IVC. So it gives this course. It gives this course like this. So it is anomalous. Pulmonary artery draining into the IVC, giving a scimitar-like density, which is a Turkish sword, a safe at Turkey. Okay. And it's associated with lung hypoplasia and all of that. Okay. So I think that's it. Thank you so much. Probably this is, we have covered some of the important issues in chest X-ray relevant to cardiology. Definitely the topic is much more prolific than this, but I meant to make it practical and just to see that, you know, the chest X-ray is never below the dignity of any cardiologist. It's still full of wealth of information. So thank you so much, and hopefully that this session was useful to you. And by this we finish.